You don't know me, but my name is Torma Ted. I was a Marine in Iwo Jima. I lost my best friend. There. The trauma caused the right side of my brain to ignite and overpower the left. I became a savant. Then I became a psychology major and PMHNP. I can't help my Marine instincts. I can't. They'll leave no man behind. I created this channel to share knowledge and create understanding. That way I can send my brainwaves out to help others. And not my soul.
Practice questions, antipsychotics and more. Question 1. EPS recognition. A 22-year-old male is brought to the ED 6 hours after receiving his first dose of haloperidol, 10 mg IM, for acute psychosis. He presents with his neck twisted to the right, eyes deviated upward, and jaw clenched shut. He is in significant distress. What is the diagnosis and immediate treatment? Answer: acute dystonia. Treat with IM benztropine, cogentine, 1 to 2 mg, or IM diphenhydramine, Benadryl, 50 mg. This is a classic presentation of acute dystonia: torticollis, neck twisting, oculogyric crisis, eyes rolling up, and trismus, jaw clenching. It occurred within hours of a high-potency FGA in a young male, the highest risk demographic. The treatment works within minutes. After resolution, start oral benztropine prophylaxis to prevent recurrence. The key exam point is that acute dystonia is treated with anticholinergics or antihistamines, not benzodiazepines, which are better for akathisia. Question 2. Akathisia versus anxiety. A patient started on risperidone 4 mg per day. 2 weeks ago, reports feeling restless and unable to sit still. The patient is pacing in the exam room and says, "I feel like I need to keep moving or I'll go crazy." The patient denies worry, racing thoughts, or panic symptoms. What is the most likely diagnosis and what is the best initial treatment? Answer: akathisia. Reduce the risperidone dose or add propranolol 20 to 40 mg BID. The timing: days to weeks after starting. The motor restlessness, pacing, inability to sit still, and the absence of cognitive anxiety symptoms, no worry, no racing thoughts, all point to akathisia, not anxiety. This distinction is critical because treating akathisia with a benzodiazepine alone is suboptimal. Propranolol, a beta blocker, is first line. Anticholinergics like benztropine are less effective for akathisia than for dystonia or Parkinsonism. The most important intervention is dose reduction or switching to a lower-risk agent. Question 3. Tardive dyskinesia management. A 58-year-old woman on haloperidol for 15 years presents with involuntary lip smacking, tongue protrusion, and finger movements. Her AIM score is 18, moderate to severe. She cannot be switched off her antipsychotic due to severe treatment-resistant psychosis. What is the first-line pharmacological treatment? Answer: a VMAT2 inhibitor, valbenazine, Ingrezza, or deutetrabenazine, Austedo. These are the only FDA-approved medications for tardive dyskinesia. They work by inhibiting vesicular monoamine transporter 2, which depletes presynaptic dopamine and reduces involuntary movements. Valbenazine is dosed once daily, starting 40 mg, target 80 mg. Deutetrabenazine is dosed twice daily, starting 6 mg BID, titrate up. The exam trap here is increase the anticholinergic benztropine. This is wrong because anticholinergics can actually worsen tardive dyskinesia. They help acute EPS but hurt TD. Another trap is stop the antipsychotic. While ideal, this patient can't be taken off her medication, and abrupt withdrawal can paradoxically worsen TD temporarily. Question 4. NMS recognition. A 35-year-old patient was started on haloperidol decanoate, long-acting injectable, 5 days ago. The nurse reports a temperature of 104 degrees Fahrenheit, 40 degrees Celsius, heart rate 130, blood pressure fluctuating between 180 over 190 over 60, and the patient is stiff as a board and barely responsive. CK level returns at 45,000 units per litre. WBC is 15,000. What is the diagnosis and what are the immediate steps? Answer: neuroleptic malignant syndrome, NMS. All 4 PHAM criteria are present: fever, 104 degrees Fahrenheit, autonomic instability, tachycardia, labile blood pressure, rigidity, stiff as a board, and mental status changes, barely responsive. The massively elevated CK, 45,000, confirms rhabdomyolysis, and leukocytosis, WBC 15,000, is a classic lab finding. Immediate management includes stop the antipsychotic, though the LAI formulation means the drug will persist in the system for weeks, making this case more dangerous. Transfer to ICU, aggressive IV fluid resuscitation, target urine output 200 to 300 milliliters per hour. Cooling measures, and start dantrolene for rigidity/hyperthermia. Bromocriptine or amantadine, dopamine agonists, can be added. Monitor renal function closely for rhabdomyolysis-induced acute kidney injury. The exam trap is that NMS from a long-acting injectable lasts longer because the drug can't be stopped. It's already in the muscle depot. Risperidone/paliperidone are potent D2 blockers among SGAs, effective but carry the highest prolactin elevation risk of all SGAs, can cause galactorrhea, amenorrhea, sexual dysfunction, and long-term osteoporosis risk. Paliperidone is the active metabolite of risperidone and is available as a long-acting injectable, Invega Sustenna/Trinza. Quetiapine, Seroquel, has very loose D2 binding, low EPS risk but high sedation, strong H1 blockade, and significant metabolic risk. At low doses, 25 to 100 milligrams, it acts primarily as an antihistamine/sedative, which is why it's widely misused for insomnia. Ziprasidone, Geodon, is metabolically friendly but carries the highest QTc prolongation risk among SGAs, requires baseline ECG, and must be taken with food. Absorption doubles with food. Lurasidone, Latuda, is metabolically clean and FDA approved for bipolar depression, both monotherapy and adjunctive. Must be taken with at least 350 calories of food for absorption. Cannot be used with strong CYP3A4 inhibitors or inducers. Question 5. Metabolic monitoring. A PMHNP starts a 30-year-old patient on olanzapine 10 milligrams for schizophrenia. Baseline labs show fasting glucose 95 milligrams per deciliter, HbA1c 5.4%, total cholesterol 190, LDL 110, triglycerides 140, and BMI 26. When should the first follow-up metabolic labs be drawn? Answer: at 12 weeks, 3 months. The standard metabolic monitoring protocol calls for weight checks at 4, 8, and 12 weeks. But the first repeat labs, fasting glucose/HbA1c and fasting lipid panel, are drawn at 12 weeks. This is especially important for olanzapine, which is one of the highest metabolic risk antipsychotics. If the patient gains greater than or equal to 7% of baseline body weight at any point, this is clinically significant and should prompt consideration of switching to a metabolically safer agent, aripiprazole, ziprasidone, or lurasidone. After the 12-week labs, repeat annually, or every 12 to 16 weeks for high-risk agents per ADA guidelines. Question 6. NMS versus serotonin syndrome. A patient on an antipsychotic presents with fever of 103 degrees Fahrenheit, altered mental status, and abnormal movements. The nurse asks how to differentiate NMS from serotonin syndrome. Which clinical finding is most specific for serotonin syndrome rather than NMS? Answer: clonus, especially lower extremity clonus. This is the classic differentiator. NMS presents with lead pipe rigidity. The patient is stiff, with no clonus or hyperreflexia. Serotonin syndrome presents with clonus, rhythmic, involuntary muscle contractions, especially in the ankles, hyperreflexia, and myoclonus, sudden muscle jerks. Other differences: NMS develops over days and resolves over 7 to 10 days after drug discontinuation. Serotonin syndrome develops over hours and resolves within 24 to 72 hours. Question 7. Clozapine REMS monitoring, APM-HNP, starts a patient with treatment-resistant schizophrenia on clozapine after 2 failed antipsychotic trials. The patient tolerates the medication well and has been on it for 8 months with stable ANC values. How often should the ANC be monitored at this point? A. Weekly. B. Every 2 weeks. C. Monthly. D. Every 3 months. Answer B. Every 2 weeks. The clozapine REMS monitoring schedule is weekly for the first 6 months, then every 2 weeks for months 6 to 12, then monthly thereafter. At 8 months, this patient is in the bi-weekly monitoring window. The exam loves to test these exact time cutoffs. Also remember that clozapine must be stopped if ANC falls below 1,000 per microliter in the general population, or below 500 per microliter in patients with benign ethnic neutropenia/BEN. The prescriber, pharmacy, and patient must all be registered with the clozapine REMS program before treatment can begin. 1 to 2. Question 8. Clozapine side effect. Priority: a patient on clozapine 400 mg per day has not had a bowel movement in 6 days. The patient reports mild abdominal bloating but denies pain. Vital signs are stable. What is the PMHNP's priority concern? A. This is a minor side effect. Recommend fiber and fluids. B. This is potentially life-threatening. Assess for ileus immediately. C. Reduce the clozapine dose. D. Switch to olanzapine. Answer B. This is potentially life-threatening. Assess for ileus immediately. This is one of the most under-recognized dangers of clozapine. Clozapine-induced gastrointestinal hypomotility kills more patients than a granulocytosis. Constipation can progress to ileus, bowel obstruction, ischemia, perforation, and death. Clozapine's powerful anticholinergic effects slow colonic transit to over 4 times normal. For every 1,000 patients on clozapine, approximately 300 to 600 will develop constipation, and at least 4 will develop serious GI complications. The PMHNP should obtain an abdominal X-ray, assess for signs of obstruction, and initiate a bowel regimen. Prophylactic bowel regimens should be started at clozapine initiation. 3 to 4. Question 9. Prolactin elevation. A 28-year-old woman on risperidone 4 mg per day for 6 months reports amenorrhea and milky nipple discharge. Serum prolactin is 95 nanograms per milliliter, normal less than 25 nanograms per milliliter. Pregnancy test is negative. What is the most appropriate next step? A. Order a brain MRI to rule out prolactinoma. B. Add bromocriptine to lower prolactin AC. Switch to aripiprazole. D. Reduce risperidone to 1 mg per day. Answer C. Switch to aripiprazole. Risperidone causes the highest prolactin elevation among SGAs, with hyperprolactinemia occurring in up to 93.5% of patients in prospective studies. The prolactin elevating hierarchy is amisulpride approximately risperidone greater than paliperidone, greater than olanzapine, greater than ziprasidone, greater than quetiapine, greater than clozapine, greater than aripiprazole. Aripiprazole is the best switch option because as a D2 partial agonist, it actually lowers prolactin levels, often below baseline. A brain MRI is unnecessary when the clinical picture clearly points to medication-induced hyperprolactinemia. Simply reducing the dose may not be sufficient because risperidone elevates prolactin significantly even at low doses. Question 10. Antipsychotic selection for bipolar depression. A 40-year-old patient with bipolar I disorder presents in an acute depressive episode. The patient has a BMI of 34 and pre-diabetes, HbA1c 6.2%. The PMHNP wants to select an FDA-approved medication for bipolar depression with the lowest metabolic risk. Which medication is the best choice? A. Quetiapine. B. Olanzapine/fluoxetine combination. C. Lurasidone. D. Cariprazine. Answer C. Lurasidone. 5 medications are FDA approved for acute bipolar depression: olanzapine/fluoxetine combination, quetiapine, lurasidone, cariprazine, and lumateperone. Among these, lurasidone has negligible weight gain liability and does not adversely affect metabolic homeostasis, making it ideal for this patient with obesity and prediabetes. Cariprazine also has minimal metabolic effects, but has more activating side effects: akathisia. Quetiapine is effective but causes significant weight gain and sedation. Olanzapine/fluoxetine has the highest response rate, 56.7%, but also the worst metabolic profile, 30.3%, had greater than or equal to 7% weight gain. Remember, lurasidone must be taken with at least 350 calories of food for proper absorption. Question 11. QTC prolongation. Risk: APM-HNP is selecting an antipsychotic for a patient with schizophrenia who has a baseline QTC of 470 milliseconds. The patient has a family history of long QT syndrome. Which antipsychotic should be avoided? A. Aripiprazole, B. Olanzapine, C. Ziprasidone, D. Lurasidone. Answer: C. Ziprasidone. Ziprasidone carries the highest QTC prolongation risk among commonly used SGAs. In pharmacovigilance data, Certindole and Ziprasidone had the highest reporting odds ratios for QT prolongation. The FDA label for Ziprasidone, Geodon, specifically warns about QTC prolongation and states it should not be used in patients with known QT prolongation, recent acute MI, or uncompensated heart failure. Aripiprazole and lurasidone have the lowest QTC prolongation risk. For this patient with a borderline prolonged QTC and family history of long QT syndrome, ziprasidone is contraindicated. The safe choices here would be aripiprazole or lurasidone. Question 12. High potency versus low potency FGAAPMHNP is reviewing the side effect profiles of first-generation antipsychotics. A nursing student asks why haloperidol causes more EPS than chlorpromazine. What is the correct explanation? A. Haloperidol blocks more serotonin receptors. B. Haloperidol has tighter D2 receptor binding and less histamine/alpha-1 blockade. C. Chlorpromazine is a D2 partial agonist. D. Haloperidol crosses the blood-brain barrier more slowly. Answer: B. Haloperidol has tighter D2 receptor binding and less histamine/alpha-1 blockade. This is the classic potency seesaw. High potency FGAs, haloperidol, flufenazine, bind D2 receptors very tightly with minimal affinity for histamine, H1 and alpha-1 adrenergic receptors, resulting in more EPS but less sedation, weight gain and orthostatic hypertension. Low-potency FGAs, chlorpromazine, thioridazine, have looser D2 binding but strong H1 and alpha-1 blockade, resulting in less EPS but more sedation, weight gain, and orthostatic hypertension. Neither is a partial agonist. That's a third-generation mechanism. The exam loves this seesaw concept. Question 13. Treatment-resistant schizophrenia. A 32-year-old patient with schizophrenia has failed adequate trials, 6+ weeks at therapeutic doses, of risperidone and olanzapine. Persistent auditory hallucinations and paranoid delusions continue to significantly impair functioning. What is the next pharmacological step? A. Add an SSRI for augmentation. B. Switch to a third antipsychotic, aripiprazole. C. Initiate clozapine. D. Add valproate for augmentation. Answer: C. Initiate clozapine. Clozapine is the only antipsychotic with proven superiority for treatment-resistant schizophrenia, defined as failure of at least 2 adequate antipsychotic trials. Guidelines universally recommend clozapine at this point, not a third standard antipsychotic trial. Delaying clozapine is associated with worse outcomes. Despite its side effect burden, a granulocytosis risk requiring REMS monitoring, metabolic syndrome, myocarditis, seizures, constipation/ileus, Clozapine is associated with the lowest all-cause mortality of any antipsychotic in real-world data. The starting dose is 12.5 milligrams once or twice daily, titrated gradually to 150 to 225 milligrams twice daily by week 2, with a maximum of 900 milligrams per day. Question 14. Clozapine myocarditis. A patient started on clozapine 3 weeks ago develops fever, tachycardia, chest pain, and fatigue. Troponin is elevated. CRP is markedly elevated. ECG shows sinus tachycardia with nonspecific ST changes. What is the most likely diagnosis? A. Neuroleptic malignant syndrome. B. Clozapine-induced myocarditis. C. Pulmonary embolism. D. Acute coronary syndrome. Answer B. Clozapine-induced myocarditis. Clozapine-induced myocarditis occurs in approximately 1% of patients, typically within the first 4 weeks of treatment. Peak incidence weeks 2 to 3. It presents with fever, tachycardia, chest pain, dyspnea, and fatigue. The key labs are elevated troponin and elevated CRP. Both should be monitored at baseline and weekly for at least the first month of clozapine treatment. This is not NMS. No rigidity, no lead pipe stiffness, no massively elevated CK. Treatment requires immediate clozapine discontinuation and cardiology consultation. The VA/DOD guidelines specifically recommend obtaining troponin and CRP at baseline and monitoring weekly for at least the first month. Question 15. Anticholinergic burden. APMHNP is reviewing the medication list of a 70-year-old patient on olanzapine 10 mg, benztropine 2 mg BID, oxybutynin 5 mg BID, and diphenhydramine 25 mg at bedtime. The patient reports confusion, dry mouth, blurred vision, constipation, and urinary retention. What is the primary concern? A. Olanzapine toxicity. B. Cumulative anticholinergic burden. C. Early onset dementia. D. Benztropine-induced Parkinsonism. Answer B. Cumulative anticholinergic burden. This patient is on 4 medications with anticholinergic properties: olanzapine, moderate; benztropine, high; oxybutynin, high; and diphenhydramine, moderate. The cumulative anticholinergic burden causes the classic anti-side effects: dry mouth, anti-salivation, blurred vision, anti-accommodation, constipation, anti-peristalsis, urinary retention, anti-detrusor, confusion/delirium, anti-cognition, and tachycardia, anti-vagal. In elderly patients, anticholinergic burden is associated with cognitive decline, falls, and increased mortality. The PMHNP should systematically reduce the anticholinergic load. Consider stopping benztropine. Is EPS still present? Switching oxybutynin to mirabegron, a beta-3 agonist with no anticholinergic effects, and eliminating diphenhydramine. Question 16. Antipsychotic in pregnancy. A 29-year-old pregnant woman, 12 weeks gestation, with schizophrenia requires continued antipsychotic treatment. She is currently on risperidone. Which concern is most specific to risperidone/paliperidone use during pregnancy? A. Neural tube defects. B. Ebstein's anomaly. C. Persistent neonatal hyperprolactinemia. D. Gestational diabetes from metabolic effects. Answer C. Persistent neonatal hyperprolactinemia. While all antipsychotics cross the placenta, risperidone and paliperidone are unique in causing the most significant prolactin elevation. Neonatal effects can include hyperprolactinemia in the newborn. Neural tube defects are associated with valproate, not antipsychotics. Ebstein's anomaly is associated with lithium. While metabolic effects are a concern with some SGAs, the most specific concern with risperidone is prolactin-related. General neonatal risks from third trimester antipsychotic exposure include extrapyramidal signs and withdrawal symptoms in the newborn, FDA class warning for all antipsychotics. The decision to continue or switch should weigh the risk of relapse against medication-specific risks. Question 17. D2. Partial agonist paradox. A patient with acute psychosis is started on aripiprazole 15 milligrams per day. After 3 days, the patient's hallucinations and agitation appear worse. The nurse reports the patient is more restless and internally stimulated. What is the most likely explanation? A. The dose is too low. B. Aripiprazole's D2 partial agonism is adding dopamine activity in a hyperdopaminergic state. C. The patient is developing NMSD. This is akathisia from aripiprazole. Answer B. Aripiprazole's D2 partial agonism is adding dopamine activity in a hyperdopaminergic state. This is the D2 partial agonist paradox. Unlike full D2 antagonists that completely block dopamine, aripiprazole acts as a dimmer switch. It reduces dopamine activity to about 30% of maximum. In a patient with an already hyperdopaminergic state, acute psychosis, this 30% residual activity can actually worsen psychosis compared to a full antagonist that would bring activity to near zero. This is why aripiprazole is sometimes less effective in acute severe psychosis and may even cause initial worsening. The solution is to switch to a full D2 antagonist, risperidone, olanzapine, haloperidol. Note: akathisia, answer D, is common with aripiprazole, but the question describes worsening psychosis, hallucinations, not just restlessness. Question 18. AIMS screening frequency. A 72-year-old woman has been on haloperidol 5 milligrams per day for 2 years. She has no current signs of tardive dyskinesia. How often should the PMHNP screen for TD using the AIMSA? Every 12 months? B. Every 6 months? C. Every 3 months? D. Only if symptoms develop? Answer C. Every 3 months. This patient has 3 major risk factors for tardive dyskinesia: elderly age, female sex, and long-term FGA use. The standard AIMS screening schedule is every 6 to 12 months for most patients, but for high-risk patients, elderly on FGAs, screening should be performed every 3 months. The annualized incidence of TD is approximately 6.5% with FGAs versus 2.6% with SGAs, and older adults are at significantly higher risk. Waiting for symptoms to develop, answer D, is wrong. TD screening should be proactive because early detection allows intervention before movements become irreversible. Question 19. Switching antipsychotics for weight gain. A 25-year-old patient with schizophrenia has been stable on olanzapine 20 milligrams per day for 1 year. However, the patient has gained 15 kilograms, 33 pounds. Fasting glucose is now 118 milligrams per deciliter, pre-diabetes, and triglycerides are 280 milligrams per deciliter. What is the most appropriate intervention? A. Add metformin and continue olanzapine. B. Cross-taper to aripiprazole. C. Reduce olanzapine to 10 milligrams per day. D. Add orlistat for weight loss. Answer B. Cross-taper to aripiprazole. While adding metformin can help with weight and metabolic parameters, the most appropriate intervention for a young patient with significant metabolic deterioration is to switch to a metabolically safer antipsychotic. Aripiprazole is the only antipsychotic that showed no change or improvement across all metabolic parameters compared to placebo in a network meta-analysis of 18 antipsychotics. The cross-taper should be done gradually to minimize relapse risk. Simply reducing the olanzapine dose risks psychotic relapse without fully addressing the metabolic problem. If the patient cannot be switched, for example, olanzapine is the only effective agent, then adding metformin is a reasonable second-line strategy. Question 20. Long-acting injectable indications. A patient with schizophrenia has had 4 hospitalizations in 2 years, each preceded by medication non-adherence. The patient reports, "I just forget to take my pills." What is the most appropriate recommendation? A. Increase the oral dose to simplify the regimen. B. Add a pill organizer and alarm reminders. C. Switch to a long-acting injectable, LAI, antipsychotic. D. Refer to a group home for supervised medication administration. Answer C. Switch to a long-acting injectable, LAI, antipsychotic. LAI antipsychotics are specifically designed for patients with adherence challenges. Available LAI options include paliperidone palmitate, Invega Sustenna monthly, Invega Trinza every 3 months, Invega Hafiera every 6 months, aripiprazole, Abilify Maintainer monthly, Aristada monthly to every 2 months, and haloperidol decanoate and flufenazine decanoate, FGAs. For a patient with recurrent hospitalizations due to non-adherence, LAIs are the evidence-based solution. Pill organizers and alarms are helpful but insufficient for a patient with 4 hospitalizations. The VA/DOD guidelines recommend LA is for patients with a history of non-adherence leading to relapse. Question 21. Antipsychotic-induced weight gain mechanism. A nursing student asks the PMHNP why clozapine and olanzapine cause more weight gain than aripiprazole. Which receptor profile best explains this difference? A. Clozapine and olanzapine have stronger D2 blockade. B. Clozapine and olanzapine block H1, 5, HT2C, and M3 receptors. Aripiprazole does not. C. Aripiprazole blocks more alpha. 1 receptors D. Clozapine and olanzapine increase serotonin release. Answer B. Clozapine and olanzapine block H1, 5, HT2C, and M3 receptors. Aripiprazole does not. The metabolic effects of antipsychotics are driven by 3 key receptors. H1, histamine, blockade increases appetite and weight gain. 5, HT2C, serotonin. Blockade increases appetite and carbohydrate craving, and M3, muscarinic blockade, directly impairs insulin secretion from pancreatic beta cells, causing diabetes even without weight gain. Clozapine and olanzapine have high affinity for all 3 receptors, explaining why they're the worst metabolic offenders. Aripiprazole has low affinity for all 3, explaining its metabolic safety. This is not about D2 blockade strength. Clozapine actually has the weakest D2 binding of all antipsychotics. Question 18. Ames screening frequency. A 72-year-old woman has been on haloperidol 5 mg per day for 2 years. She has no current signs of tardive dyskinesia. How often should the PMHNP screen for TD using the AIMSA? Every 12 months, B. Every 6 months, C. Every 3 months, D. Only if symptoms develop. Answer C. Every 3 months. This patient has 3 major risk factors for tardive dyskinesia: elderly age, female sex, and long-term FGA use. The standard AIMS screening schedule is every 6 to 12 months for most patients, but for high-risk patients, elderly on FGAs, screening should be performed every 3 months. The annualized incidence of TD is approximately 6.5% with FGAs versus 2.6% with SGAs, and older adults are at significantly higher risk. Waiting for symptoms to develop, answer D, is wrong. TD screening should be proactive because early detection allows intervention before movements become irreversible. Question 19. Switching antipsychotics for weight gain. A 25-year-old patient with schizophrenia has been stable on olanzapine 20 mg per day for 1 year. However, the patient has gained 15 kilograms, 33 pounds. Fasting glucose is now 118 mg per deciliter, pre-diabetes, and triglycerides are 280 mg per deciliter. What is the most appropriate intervention? A. Add metformin and continue olanzapine. B. Cross-taper to aripiprazole. C. Reduce olanzapine to 10 mg per day. D. Add orlistat for weight loss. Answer B. Cross-taper to aripiprazole. While adding metformin can help with weight and metabolic parameters, the most appropriate intervention for a young patient with significant metabolic deterioration is to switch to a metabolically safer antipsychotic. Aripiprazole is the only antipsychotic that showed no change or improvement across all metabolic parameters compared to placebo in a network meta-analysis of 18 antipsychotics. The cross-taper should be done gradually to minimize relapse risk, simply reducing the olanzapine dose risks psychotic relapse without fully addressing the metabolic problem. If the patient cannot be switched, for example, olanzapine is the only effective agent, then adding metformin is a reasonable second-line strategy. Question 20. Long-acting injectable indications. A patient with schizophrenia has had 4 hospitalizations in 2 years, each preceded by medication non-adherence. The patient reports, "I just forget to take my pills." What is the most appropriate recommendation? A. Increase the oral dose to simplify the regimen. B. Add a pill organizer and alarm reminders. C. Switch to a long-acting injectable, LAI, antipsychotic. D. Refer to a group home for supervised medication administration. Answer C. Switch to a long-acting injectable, LAI, antipsychotic. LAI antipsychotics are specifically designed for patients with adherence challenges. Available LAI options include paliperidone palmitate, Invega Sustenna monthly, Invega Trinza every 3 months, Invega Hafiera every 6 months, aripiprazole, Abilify Maintainer monthly, Aristada monthly to every 2 months, and haloperidol decanoate and flufenazine decanoate, FGAs. For a patient with recurrent hospitalizations due to non-adherence, LAIs are the evidence-based solution. Pill organizers and alarms are helpful but insufficient for a patient with 4 hospitalizations. The VA/DOD guidelines recommend LA is for patients with a history of non-adherence leading to relapse. Question 21. Antipsychotic-induced weight gain mechanism. A nursing student asks the PMHNP why clozapine and olanzapine cause more weight gain than aripiprazole. Which receptor profile best explains this difference? A. Clozapine and olanzapine have stronger D2 blockade. B. Clozapine and olanzapine block H1, 5-HT2C and M3 receptors. Aripiprazole does not. C. Aripiprazole blocks more alpha. 1 receptors D. Clozapine and olanzapine increase serotonin release. Answer B. Clozapine and olanzapine block H1, 5-HT2C and M3 receptors. Aripiprazole does not. The metabolic effects of antipsychotics are driven by 3 key receptors. H1, histamine, blockade increases appetite and weight gain. 5-HT2C, serotonin. Blockade increases appetite and carbohydrate craving, and M3, muscarinic blockade, directly impairs insulin secretion from pancreatic beta cells, causing diabetes even without weight gain. Clozapine and olanzapine have high affinity for all 3 receptors, explaining why they're the worst metabolic offenders. Aripiprazole has low affinity for all 3, explaining its metabolic safety. This is not about D2 blockade strength. Clozapine actually has the weakest D2 binding of all antipsychotics. Question 22. Ziprasidone administration. A patient on ziprasidone 80 mg. BID reports that the medication isn't working. The PMHNP discovers the patient has been taking it on an empty stomach every morning. What is the most important counseling point? A. The dose needs to be increased to 100 mg BIDB. Ziprasidone must be taken with food. Absorption doubles with at least 500 calories. C. Switch to a different antipsychotic. D. Add a mood stabilizer for augmentation. Answer B. Ziprasidone must be taken with food. Ziprasidone has a unique pharmacokinetic requirement. Its absorption approximately doubles when taken with food, at least 500 calories. A patient taking ziprasidone on an empty stomach may only be absorbing about half the intended dose, which explains the apparent treatment failure. Before concluding the medication has failed, the PMHNP should ensure proper administration with food. This is one of the most commonly tested pharmacokinetic facts about antipsychotics on board exams. Similarly, lurasidone requires at least 350 calories for optimal absorption. 12. Question 23. NMS risk after recovery. A patient recovered from NMS 3 weeks ago after haloperidol was discontinued. The patient's psychosis is worsening and requires antipsychotic treatment. What is the safest approach to restarting an antipsychotic? A. Restart haloperidol at a lower dose. B. Wait at least 2 weeks. Already met? Then start a low-potency SGA like quetiapine at the lowest dose with very slow titration. C. Start clozapine immediately at full therapeutic dose. D. Antipsychotics are permanently contraindicated after NMS. Answer B. Start a low-potency SGA like quetiapine at the lowest dose with very slow titration. After NMS resolves, antipsychotics are not permanently contraindicated, but rechallenge requires extreme caution. The recommended approach is to wait at least 2 weeks after NMS resolution. This patient has waited 3 weeks. Sufficient. Choose a different chemical class from the offending agent, not haloperidol again. Select a low-potency agent with loose D2 binding. Quetiapine or clozapine are preferred. Start at the lowest possible dose and titrate very slowly with close monitoring of temperature, vital signs, CK, and mental status. High-potency agents like haloperidol carry the highest NMS recurrence risk. The recurrence rate with rechallenge is estimated at 10 to 30%, so informed consent is essential. 18. Score yourself. Questions 7 to 23. 15 to 17. Correct, antipsychotic master. Ready for boards. 12 to 14. Correct, strong foundation. Review clozapine monitoring and metabolic details. 9 to 11. Correct, building knowledge. Focus on receptor profiles and side effect mechanisms. Below 9, go back to the study guide, master the FGA versus SGA differences first. Top exam traps from these questions. Clozapine's biggest killer is a granulocytosis. Wrong. GI hypomotility/ileus kills more clozapine patients than a granulocytosis. Order MRI for high prolactin on risperidone. Wrong, it's medication-induced. Switch to aripiprazole. First aripiprazole worsens psychosis equals NMS. Wrong, it's the D2 partial agonist paradox. Not an emergency, just switch agents. Ziprasidone isn't working. Check if patient is taking it with food. Absorption doubles. NMS equals never use antipsychotics again. Wrong. Rechallenge is possible with a different class, low dose, slow titration, AIM screening only when symptoms appear. Wrong. Screen proactively every 3 months in high-risk elderly patients' references. These additional questions cover the highest yield antipsychotic topics for PMHNP boards, including clozapine REMS monitoring schedules, life-threatening GI hypomotility, prolactin management, FDA-approved agents for bipolar depression, QTC prolongation risk stratification, metabolic receptor mechanisms, and NMS rechallenge protocols. Each question is designed to target common exam traps and reinforce the clinical reasoning patterns tested on certification exams.
Thanks for watching. Like and subscribe for more content.